mean by brachial plexus? So under these headings, that is, what is brachial plexus, where its location, formation, components, branches, and applied aspects has to be written. It's a common long essay, and part of it can be asked as 3 marks or 5 mark questions. So here, brachial plexus is basically a plexus of nerves which are formed by the ventral rami of C5 to T1 spinal nerves. So from C5 to T1 spinal nerves, so the ventral rami of them, they intermingle with each other and they form the nerve plexus that is known as the brachial plexus. So basically, we see the formation of the brachial plexus, which extends from the neck region to the axilla. Okay, so the components now. So sometimes if it receives, so usually we say the ventral rami of C5 to T1, but sometimes if it receives a contribution from C4, we call it as a prefix position. And if it receives a contribution from the ventral rami of T2, we call it as postfixed. So these are the nerves, C5, C6, C7, C8, and T1's ventral rami. And the ventral rami of C5 and C6. Okay, so basically the brachial plexus, you can think of it like a tree. Okay, so the tree will have its roots. Tree will have the trunk. Okay, then main 2 big divisions of it. And each division will be having branches. Okay, further. So you can think of something like that. Okay, so here these C5, C6, C7, C8, and T1 ventral rami, we call them as the roots. Okay, so these roots, they join to form the trunk. Okay, so there is the trunk of the tree. So this is the trunk. Okay, so how they join? The ventral rami of C5 and C6, it joins to form the upper trunk. Okay, this is called the upper trunk. C7 continues as the middle trunk. C8 and T1 ventral rami join to form the lower trunk. So there is upper trunk, middle trunk, and the lower trunk. Then this trunk further divides. Okay, each trunk will divide into an anterior division and a posterior division. Okay, so here you can see the trunk is divided into an anterior division and a posterior division, anterior and a posterior. Anterior, this is the anterior and this is the posterior. Okay, so these are the divisions. So trunk will divide into divisions. And the divisions later form the cords. So the anterior division of the upper trunk and the middle trunk join to form the lateral cord. Okay, the anterior division of the lower trunk continues as medial cord, and the posterior divisions of all the 3 join to form the posterior cord. Okay, so there is a lateral cord, medial cord, and a posterior cord. So these are the 3 cords, and the cords will further give branches. Okay, so this is how we see. Okay, C5, these are the roots, the trunks, the divisions, and the cords and the branches. So we will go from the branches from the roots. Okay, so in the roots, the C5, okay, C5 root gives, so when you talk about the branches, we need to talk about the branches from the root. So from the root, the C5 will give the dorsal scapular nerve. Okay, and C5, C6, C7, they join to form the long thoracic nerve, or the nerve to serratus anterior, long thoracic nerve. Okay, so those are the branches from the roots. Okay, so we have C5 forming the dorsal scapular and C5, C6, C7 forming the long thoracic. Then we have from the trunk. Okay, so from the trunk, only the upper trunk will give branches. Okay, so we have the nerve to subclavius. So from the trunk, we'll have 2 branches. Okay, that is nerve to subclavius as well as suprascapular nerve. Okay, suprascapular as well as the subclavius, nerve to subclavius. So they are from the trunk. Okay, divisions do not give any branches, and the next branches are from the cords. Okay, so from the cords, we have the branches. So to remember, so which are the 3 cords now? We have the lateral cord, We have the medial cord and we have the posterior cord. Okay. So what are the branches? So lateral cord will give. Okay. So here if you see, the lateral cord will give okay. One is the lateral pectoral nerve, the lateral root of median, and the musculocutaneous nerve. Okay, LLM. So it gives three. The lateral pectoral, then the lateral cord. Here you can see one is the lateral pectoral nerve. Then it gives the lateral root of median. Here you can see this is the lateral root of median. And rest it continues as musculocutaneous nerve. Okay, that is from the lateral cord. Then coming from the medial cord, okay, medial cord will give, you can remember the mnemonic as M for you. So what are these 4 M's? Okay, so when we talk about the 4 M's, medial pectoral nerve. Then after that, the next M will be medial cutaneous nerve of arm, medial cutaneous nerve of arm. Okay, then the next M, third M is the medial cutaneous nerve of forearm. And the fourth M here is medial cord of median nerve. Okay, medial cord of median nerve. And U is, it will continue as ulnar. Okay, that is for the medial cord. And for the posterior cord, we can remember the mnemonic as ulnar. Okay, so here U stands for upper subscapular. L is for lower subscapular. N is nerve to latissimus dorsi. Okay, or thoracodorsal, we can remember as nerve to latissimus dorsi muscle. It is otherwise called as thoracodorsal nerve. A is axillary. And R is radial. Okay, so these are the branches from the cords. So this is how we can remember. Okay, so here you can show in different colors just to know which are roots, trunks and all, to show that. Okay, you can show it. So here, no, these cords, when it is in the axilla, because roots we see it in the neck region. Okay, roots and trunks. The divisions form behind the clavicle. And the cords, we see it in the axillary region. So in the axilla, especially in the second part of the axilla, like, first and second part, we see the roots. So the posterior, so this is the axillary artery. So axillary, medial to the axillary artery will be the medial cord, lateral to it will be the lateral cord, and posterior to it will be the posterior cord. And in front of the axillary artery, the median nerve will form from the lateral root and the medial root of median. The median nerve will be forming. So this point, okay, so where 6 nerves meet, that is called as the Erb's point. So what are those 6 nerves? C5, ventral rami of C5, ventral rami of C6, suprascapular nerve, nerve to subclavius, anterior division and posterior division, okay, of the upper trunk. So all these 6 nerves together, we call it as the Erb's point. So it is very important because it is the common site of injury, which leads to Erb's palsy. Okay, so that is why it is important. So coming to the applied aspects, okay, so usually brachial plexus injuries, one, we can see any avulsed nerve, where the nerve is totally avulsed from its root, or a ruptured nerve in its pathway, or sometimes because of traction, it can be stretched also. So these kind of injuries can happen to the nerve, avulsed or ruptured or stretched. Okay. So here in the during the normal delivery, okay, because of excessive traction, that is the stretching, right? So what happens is here near the neck region, okay, where near the neck region, what is happening? Trunks are forming, the trunks are dividing into divisions, right? And especially the Erb's point, at Erb's point, what is happening? 6 nerves are meeting. So there is traction there. Okay, so because of that traction, there is injury to the nerves there. Understand? So that will lead to what we call it as the Erb's palsy. So Erb's palsy, one is because of the excessive traction there, or sometimes a fall on the outstretched hand can also lead to Erb's paralysis. Okay. So what happens here? If you see, the arm is adducted, okay, and the arm and the forearm, like, it is adducted there, and it is medially rotated, and the hand here, it is turned backwards. Okay. So it is like supinated posteriorly like this. So this is known as this typical deformity. We call it as the polytip deformity. Okay. So like asking for a tip slowly, like that way. So polytip deformity we say, and this is what we see in Erb's paralysis. Then clump case. Clump case paralysis is because of the injury to the lower trunk. Okay. So lower trunk here, what happens is, especially when there is sometimes the limb presence instead of the head, sometimes there will be either the foot presentation or the hand presence. So when there is stretching here, okay, so the lower trunk gets stretched, okay, so that will lead to clump case paralysis. Clump case paralysis, otherwise here also, like, you hang on to something for a very long time, there will be undue stretching here, and that can lead to lower trunk. Lower trunk is basically, it forms the which cord? The medial cord, and medial cord continues as the ulnar nerve, right? So it can lead to claw hand deformity. Then from the root, we had the long thoracic nerve from the C5, C6, C7, that is which supplies the serratus anterior. So when that is affected, there can be winging of the scapula. So these are the things which you need to write. Okay. So you will write about the what do we mean by this thing? Brachial plexus. So we need to write from C5 to T1. Okay, ventral rami of C5 to C5, T1, C5, C6, C7, and T1. So if it receives contribution from C4, it is prefixed. It receives contribution from T2, it is postfixed. Okay, so where it is located, all the components, which include the roots, the trunks, the divisions, the cords, and the branches. So from the cords, we have medial cord, the lateral cord, as well as the posterior cord. So from the medial cord, you remember the mnemonic M for U, lateral cord LLM, and posterior cord ulnar. So to know the branches. Okay, so this is basically the mnemonics, and the applied aspects you need to write about it. Next, coming to the ulnar nerve. Okay, so ulnar nerve. So ulnar nerve, whenever we write about these nerves, the root value of the nerve, origin, termination, course, branches, and applied aspects. So the ulnar nerve, what is the root value? The ulnar nerve is formed by the, okay, so the ulnar nerve is basically formed by which one? From the lower trunk, isn't it? So it extends. So lower trunk is basically from where? Lower trunk is formed by the C8 and T1. C8 and T1 join to form the lower trunk. Okay, so the root value will be C8 and T1. So the ulnar nerve begins as a continuation of the medial cord of the brachial plexus. Okay, so in the axillary region, it doesn't give any branches. You can draw like this diagram. You don't have to draw the arm and all those things. You can make these divisions and you can show the structures. Okay, only thing you just show which is superior, inferior, lateral, medial like this, and show this is the ulnar nerve. So in the arm, so here it will be running medial to the brachial artery. So there what happens? It pierces, the intramuscular, medial intramuscular septa goes posteriorly, okay, goes to the posterior compartment, and near the medial epicondyle, okay, it winds around there, and then it again enters the anterior compartment. It will pierce the septa and again it will enter the anterior compartment there. So there it will be passing between the two heads of the flexor carpi ulnaris muscle. Okay, and then it runs in the forearm. Okay, forearm, and then here it passes above the flexor retinaculum, where it will end by dividing into its terminal branches. So which will be the terminal branches? It will give a superficial branch and a deep branch. Okay. So now here in the arm, it doesn't have any branches, whereas in the forearm, it supplies the elbow joint. It also supplies the flexor carpi ulnaris and the medial 1/3 of the flexor digitorum, medial half of the flexor digitorum profundus. Okay. So that is all, only those are, because rest of the muscles are supplied by the median nerve. So flexor carpi ulnaris and medial half of the flexor digitorum profundus is supplied by the ulnar nerve. Then just before it enters the hand, okay, here it gives one more branch, that is the dorsal cutaneous branch, dorsal cutaneous branch. So dorsal cutaneous branch will supply the skin on the medial side of the dorsum of the hand, okay, and medial, that is medial side will be this side. So medial side of the dorsum of the hand, for the medial 1.5 fingers it will be supplying. Then the nerve, it will pass over the flexor retinaculum, where it will divide into superficial and the deep. So superficial will supply the skin. So it will supply the medial, that is medial part of the palm, okay, 1/3 of the palm, as well as medial 1.5 digits it will supply, okay, the skin. The deep branch, as well as it will also supply superficials, that is the subcutaneous muscle, palmaris brevis. Then it will pass beneath, right? So here it will give the terminal branch. So this one is the deep terminal branch. So deep terminal branch, it will supply the wrist joint. Then it will all supply the intrinsic muscles, okay? So it will supply all the thenar hypothenar muscles, that is the flexor digiti minimi, abductor digiti minimi, and opponens digiti minimi. It supplies the third and fourth dorsal, third palmar introche and fourth dorsal introche, okay? As well as the medial two lumbricals it will supply, okay? For dorsal introche and palmar introche it supplies. Then two medial lumbricals, okay? Medial two lumbricals it will supply. It also supplies the flexor pollicis brevis and ends by supplying the adductor pollicis. So these are the muscles supplied by it, okay? So basically most of the intrinsic muscles, they're all supplied by the ulnar nerve. So ulnar nerve, since it is supplying all the intrinsic muscles, right? And intrinsic muscles are very essential, especially for a musician who plays the instruments, right? These muscles have to move. So for that sake, this ulnar nerve is also called as the musician's nerve. Okay. So when the ulnar nerve is injured, okay, ulnar nerve is injured, what happens is, here it results in partial claw hand, okay, partial claw hand. So the medial 1.5 fingers, they are affected, and there is flexion, interphalangeal, okay, because of the unopposed action of flexor digitorum profundus muscle. So there is a interphalangeal flexion, okay, so that is seen. And since it supplies the medial half of the flexor digitorum tendon, right? So only these two will be affected, which are attaching to these medial two fingers, okay? And there is sensory loss, okay? Sensory loss over it, that is the medial part of the medial 1/3 of the palm, medial 1.5 fingers, as well as the dorsal surface of the medial 1.5 fingers. The sensations is lost, okay? So that is what happens in ulnar nerve injury. Okay, so that is the things which you need to write. So always write the root value since it is coming from the nerves. Okay, C5, so C8 and T1. Okay, this will be the root value. So origin you will write. So it is a branch of the medial cord you will write. Okay, then termination, it will terminate in the hand by dividing into the terminal, superficial and deep branches. Okay, it will divide. So explain the course in the axilla, in the arm, and in the forearm, okay, as well as in the hand. So branches, it gives no branches in axilla, no branches in what is that, arm, but in forearm it gives branches. Okay, forearm, it supplies the joint, that is the elbow joint, as well as the flexor carpi ulnaris muscle and flexor digitorum profundus, that is only the medial half. Okay, medial half it will supply. Then branches, basically you talk about superficial. Okay, so superficial branches are mainly cutaneous. Okay, they are cutaneous and it supplies one muscle, that is palmaris brevis. Deep branch, they are all muscular, that supplies the wrist joint as well as all the intrinsic, most of the intrinsic muscles, okay, except for thenar as well as the medial to lumbricals. Okay, lateral to lumbricals, it doesn't supply. Then median nerve. Okay, so median nerve, when we see same thing, any nerves we need to write in the same portion, that is the root value, origin, termination, course, branches. So root value of the median nerve. The median nerve here, if you see, it is formed by which one now? It is formed by the contribution from lateral cord as well as from the medial cord. So lateral cord, the lateral root of median, and the medial root of median from the medial cord, both will join. Okay, just below the, that is near the third part of the axillary artery, in front of the axillary artery, they both join to form the median nerve. Okay, so this median nerve, it runs forwards. So here if you see, okay, median nerve, since it is contributed from both lateral and medial cord, okay, we write all the root values. So C5, C6, C7, C8 and T1. Okay, so they join to form the median nerve. So median nerve in the axilla, it doesn't have any branches or things, so it passes. So here it passes from medial to from the lateral to the medial side, it crosses the brachial artery. Okay, that is at the level of insertion of coracobrachialis, it will cross over. Then it passes in the cubital fossa. Okay, in the cubital fossa it passes. There it gives a branch to the pronator teres, passes through the two heads of the pronator teres. And this is the nerve of the forearm. Okay, so it will be supplying all the muscles of the forearm, that is superficial as well as the deep. So here it will also give anterior interosseous nerve, which will supply the flexor pollicis longa, that is the deeper muscles. Okay, deeper muscles, that is deep flexors of the forearm are supplied by the anterior interosseous nerve, that is flexor pollicis longa, flexor digitorum profundus, the lateral half of it, pronator quadratus, it supplies. Whereas from the median nerve directly, it supplies the flexor carpi ulnaris, palmaris longus, as well as the flexor digitorum superficialis. Okay. Then here, it passes, and in the near the wrist joint, it will pass beneath the flexor retinaculum. Okay. So before it passes down, it will give one more branch, that is palmar cutaneous branch. Okay, palmar cutaneous branch. So palmar cutaneous branch will be supplying the lateral 2/3 of the palm. Okay, so that is the thing. It is that branch. Then it will pass beneath the flexor retinaculum, and there it will supply the, it gives a recurrent branch supplying the thenar muscles, that is the abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. Okay, and here it will also give muscular too, that is first lumbrical and second lumbrical. Okay, and palmar digital branches it gives to supply the lateral 3.5 digits. Okay, so when this nerve is injured, what happens is there is this, okay, hand of benediction, that is like a blessing kind of hand. Okay, so what happens? They are able to flex this, but here they cannot. Okay, so it is this partially flexed. So that is called as the Benedict sign. Okay, then median claw hand. Median claw hand is only affecting the lateral 3 fingers. Okay, so when they try to extend the hand, but they cannot. The distal interphalangeal joints, they are flexed. And there is sensory deficit. Sensory deficit is on the medial 2/3 of the palm, the medial 3.5 digits, as well as on the dorsal side, it will be to the up to the nail beds. Okay, so the superior surface here, the skin over the nail bed, now that region it is affected. Okay, so this is the thing, and when both ulnar nerve and median nerve are affected, that results in a complete claw hand. Okay, another thing is the median nerve can get compressed in the carpal tunnel. Okay, and that can lead to wasting of the thenar muscles. Okay, there is wasting of the thenar muscles, and there is sensory loss. Okay, initially there will be tingling and pain sensation of the skin, but further compression, there can be sensory loss in the area supplied by the median nerve. Okay, so that is about the median nerve. So you will write about the root values. So both whatever forming C5, C6, C8 and T1. Okay, so it lists few fibers from the C7, but we don't mention that. Okay, so origin formed by the lateral root and lateral root of median and medial root of median. Okay, that is contributed from lateral cord and things. So they both join to form the median nerve in front of the axillary artery. Okay, so where does it terminate? It terminates in the hand. Okay, so the course, so from the in the forearm, how it passes from lateral to medial side, crosses the brachial artery, then it reaches the cubital fossa. Okay, so branches, it is mainly the nerve of forearm, okay, where it will supply the forearm muscles. There it gives the anterior anterior intraosseous nerve, which supplies all the deeper muscles, deep flexors it supplies. Okay, and the median nerve supplies all the superficial. So there it will be passing between the two heads of pronator teres. Okay, so branches you will read, and then you have to mention about the branches in the. So median nerve is also called as the peripheral eye. Why it is called peripheral eye? Because we use usually these two fingers to feel for any texture of the cloth or anything, right? So when we use these two fingers, so that is why it is known as the peripheral eye. Okay. The next nerve is radial nerve. So radial nerve, under the same headings, root value, origin, termination, course, branches, applied aspects you need to write. So radial nerve, okay, so radial nerve is from where? We have it from the posterior. It's a continuation of the posterior cord. So here the root value is all C5, C6, C7, C8 and T1. So all of them, they join to form the radial nerve. So radial nerve, now, okay, so here in the axilla, it gives two branches, posterior cutaneous nerve of arm, okay. So basically the radial nerve, what happens is once it is given, no, it pierces the, that is because it is given in the anterior part of the axilla. So from there it will enter the posterior part of the arm, okay, where it will give the posterior cutaneous nerve of arm and supplies the long head of triceps. After that, it enters the radial groove. Okay, along with the profunda brachii artery, it will enter the radial groove, where it will give two branches, that is for the medial head and the lateral head. So that is given within the radial groove. And within the radial groove, it also gives lower lateral cutaneous nerve of arm, okay, nerve to anconeus, then posterior cutaneous nerve of forearm. So these are the branches which it gives within the radial groove. After emerging from the radial groove, it will pierce the lateral intramuscular septa, comes to the anterior compartment where it will supply the brachialis muscle, a small part of brachialis muscle. It gives a branch to the brachioradialis as well as extensor carpi radialis longus. Okay. Then in the cubital fossa, in the cubital, that is the neck of the radius, it will divide into a superficial and a deep branch. Okay. So the deep branch here is called as the posterior intraosseous nerve. Superficial branch is called as the superficial radial nerve. So superficial radial nerve will run alongside of the radial artery, okay, where it will end up here, okay, supplying the skin on the lateral side. So it crosses these tendons, okay, and there it supplies the skin on the lateral side of the dorsum of the hand, okay, lateral side of the dorsum of the hand here. And the lateral 3.5 digits, okay, except the nail beds, because the nail beds are supplied by the median nerve. So this basically the superficial terminal branch is mainly cutaneous. Whereas the posterior intraosseous, that is a deep branch, okay, it passes between the two heads of the supinator. It gives a recurrent branch which will supply the supinator and supplies all the muscles of the forearm. Okay, so posterior intraosseous nerve supplies all the muscles of the forearm, that is the extensor muscles, whereas the radial nerve directly supplies two of the extensor muscles, that is the brachioradialis and extensor carpi radialis longus. And this nerve, it ends, okay, near the, it also supplies the inferior radioulnar joint, and near the wrist joint, it ends posteriorly, okay, where it ends by forming a pseudoganglion. So, radial nerve injury results in wrist drop, okay, because the extensor power is lost, you're not able to extend the wrist joint, okay, so it results in wrist drop. Sometimes like, sleeping over the arm, hanging by the chair or something, there'll be compression of the radial nerve, which can also lead to wrist drop. Okay, that is called as Saturday night palsy and wrist drop. It can occur. So these are the things which you need to write. Okay, so root value here, since the posterior cord is formed by all the three divisions. Okay, so C5, C6, C7, C8, and T1. All of them are its root values. So origin. Okay, so it is a branch of the posterior cord. Okay, from the axilla, it will enter the posterior compartment. So there in the posterior compartment, it will run. So you have to talk about the branches given before it enters the radial groove. And so before entering the radial groove, okay, it will give radial groove. It will give the, before that, it will give nerve to long head of triceps. Okay, long head is given there. In the radial groove, it gives branches to medial and lateral head. Okay, this is very important because if the nerve is injured in the radial groove, this long head of triceps is spared because the nerve is given before it enters the radial groove. Okay, so rest all the branches supplying the forearm, sorry, the arm. Okay, as arm as given within the radial groove. Then it enters the anterior compartment, supplies the brachialis as well as gives branches to two of the extensor muscles, and it ends in the forearm, dividing into posterior interosseous and superficial radial nerve. Superficial radial nerve is cutaneous, supplying the 3.5 digit dorsum surface of the skin over the dorsum of the hand, that is lateral part, as well as the lateral 3.5 digits it will supply, okay, except for the nail beds. And applied aspect, you need to write about wrist drop. Next is axillary nerve. Okay, so axillary nerve now, same, any nerves, same pattern, root value, origin, termination, course, branches, applied aspects. So axillary nerve is a branch from the, which one? Posterior cord. But here, though it is posterior cord, we are saying only C5, C6. Why we are saying C5, C6 is because axillary nerve is given in the axilla itself. Okay, so here it will be carrying, and the dermatomes over that region is mainly coming from C5, C6. Okay, from those regions. So that is why only those fibers will be running in the axillary nerve from C5 and C6. So once it is given in the axilla, that is coming from the posterior cord, it supplies the shoulder joint. Okay, it winds around near the neck of the humerus. Okay, and then it divides into two, posterior branch and an anterior branch. Anterior branch supplies the deltoid as well as the skin on the lower half of the deltoid, whereas the posterior branch supplies the teres minor muscle, also supplies the deltoid. Okay, and it also forms a pseudoganglion. Okay, it supplies the teres major, minor muscle, so that also forms a pseudoganglion. And it also supplies the upper lateral cutaneous, that is, it gives the upper lateral cutaneous branch to the arm to supply the skin over the lower lateral part of the deltoid. Lower lateral cutaneous branch, no, it is given by the radial. Okay, so these are the branches. So axillary nerve, so basically since it is supplying the deltoid muscle, so if the nerve is injured, the person is not able to, because deltoid is necessary for the abduction up to 90 degree, right? So it cannot abduct, so it drops down. Okay. Another thing is, in the army people and all, they tie the regimental badge here. Okay. So if the badge is very tightly tied and all those things, sometimes there may be compression over the nerve and it can lead to paralysis. So that is about axillary nerve. So axillary nerve, you talk about the root value, C5, C6. Then you go where it is formed, its divisions, that is anterior and posterior divisions. Okay, both will supply the deltoid muscle. Okay, and supplies the it gives the upper lateral cutaneous nerve of arm. Okay, so applied aspects, you will write about paralysis of deltoid muscle as well as regimental badge syndrome. Next nerve is musculocutaneous nerve. So musculocutaneous nerve, it is the nerve of the arm. Okay, that is the flexor compartment of arm. So you also follow the same pattern of root value, origin, termination, course, branches, applied aspects. Right? So you write. So here if you see, musculocutaneous nerve. So musculocutaneous nerve is given by the lateral cord, isn't it? So it is the continuation of the lateral cord. So so here why it is called musculocutaneous is, if you see its course, here in the flexor compartment of arm, it is supplying all the muscles and it is piercing through this, especially that is how we identify. It pierces through the coracobrachialis. Okay. And in the forearm, it becomes lateral cutaneous and continues as the lateral cutaneous nerve of forearm. So that is why it is called as musculocutaneous. Okay. So you can see here, okay, formed by C5, C6, C7 here. And though it is this one, okay. Right, it passes through the coracobrachialis, supplies all the muscles here, biceps brachii, brachialis, supplies, also gives a tweak to elbow joint, okay? And then it pierces the deep fascia, becomes cutaneous and continues as the lateral cutaneous nerve of forearm, supplying the lateral part of the forearm. So you remember that superficial radial nerve also will be running along the lateral aspect, but then it is running deep, whereas lateral cutaneous will be running superficial and supplying the skin. So radial nerve will supply only in the hand region. Okay. Right. So root value C5, C6, C7. Okay. Origin we will write from the lateral cord. Termination is it terminates in the forearm by continuing as the lateral cutaneous nerve of forearm. Okay, so we'll write its course. Important thing is it pierces the coracobrachialis muscle. Okay, so branches are basically muscular branches. Okay, supplying the muscles of the arm, flexor compartment. Okay, then articular branch to the joint, and cutaneous branch as lateral cutaneous nerve of forearm. Okay, to the lateral side of the forearm. So that is the applied aspect is basically, as such, there is no named syndrome, but when this nerve is affected, the flexion is lost, so muscles of the flexor compartment are affected, as well as the cutaneous sensation, so the lateral aspect of the forearm is lost. Next is cutaneous innervations. Already we have discussed this during the nurse. It is just a summary of it. Okay. So basically the hand is supplied by the ulnar nerve, the median nerve and the radial nerve. Okay. Ulnar nerve, median. So you should just know where it supplies. Okay. So ulnar nerve, if you see, it is supplying the skin medial, medial 1/3 of the palm as well as medial 1.5 fingers. Okay. In the palm. And the median nerve, supplies the medial 2/3 of the palm as well as the lateral 2/3 of the palm as well as the lateral 3.5 fingers it supplies. Okay. The radial nerve will supply the lateral aspect here of the palm little bit, and then also the dorsal aspect of the 2.5 fingers here. Okay. So it supplies. So this is actually, some books, they give up to 3.5 years. Okay, there is a little thing, but most of the things they give is this way. So here, it supplies only up to the nail beds because the nail beds are supplied by the median nerve. Okay, the ulnar nerve supplies the medial 2.5 digits here, as well as the medial aspect of the dorsum of the hand skin over the dorsum. Okay, so this is the distribution. Cutaneous distribution. So, so it's very important. You can just draw the diagram and show. Okay, where is the distribution like this? Okay, so here you can see it is shown as 3.5 fingers. So usually we take it that way, 3.5 fingers median nerve on the front, 3.5 fingers radial nerve on the dorsum. Okay, so now supplying are all the 3 nerves and the distribution. So branches, basically it gives the palmar branch, palmar cutaneous branch and digital branches. Okay, these are the digital branches it gives. So median nerve, it will give the lateral and medial branches. So it will be supplying the muscles as well as the, so muscular branches are for the thenar group of muscles. Coming to the short answers, so brachialis muscle. So any muscle, we talk about origin, insertion, nerve supply, action. So brachialis origin. Origin is from the anterior surface of the shaft of the humerus. Humerus. Okay, so in the lower part, it has its origin, lower half of the anterior surface of the humerus. It gets inserted into the anterior surface of the coronoid process of the ulna. Okay, anterior surface of the coronoid process of the ulna, it gets inserted. Okay, so it is mainly, it brings about flexion of the elbow. So this muscle here, you should know, it has got dual nerve supply. So it is known as the hybrid muscle because it is supplied both by radial nerve as well as musculocutaneous nerve. So if the musculocutaneous nerve is injured, brachialis muscle is spared because partially there is no complete loss of flexion there, okay, because of the supply by the radial nerve also. So that is what you need to write. So origin, insertion, nerve supply, action, and boundaries and contents of axilla. Now, axilla is a pyramidal space, okay, between that is the lateral part of the thoracic wall as well as the medial aspect of the shaft of the humerus. Okay, so the head and that neck and the shaft portion, upper part, we will see this pyramidal space truncated. We don't say it is completely pyramidal because the apex doesn't meet, the two walls don't meet there. Instead, it is open, okay, because it forms a canal, which we call it as the cervico-axillary canal. So the apex is truncated. So it will have a lateral wall, a medial wall, posterior wall, and an anterior wall. Okay, so if you see behind is posterior, this will be the anterior, this is lateral, this is medial, and this is the base, this is the apex. Okay, so we should know what forms what here. So the apex here, it's not pointed, it is truncated, and it is formed medially by the clavicle here. Okay, medially by the first rib here, and in front, okay, this is the clavicle, and on the side, the acromial process. Okay, so this is the superior border of the scapula here. So this is the acromial process. So this is the apex of the triangle. Of the axilla. Okay, so it is bounded here. You can see outer border of the first rib, the middle third of the clavicle, and the upper border of the scapula. So since most of the structures from the neck region enter, okay, or from the axilla, they go to this region, we call it, it forms a canal, which we call it as the cervico-axillary canal, the apex. Then the base is formed by the skin superficial fascia, okay, and it is held in position like a dome-shaped base by the attachment of clavipectoral fascia. So it basically forms the outlet. Then coming to the walls, now it will have an anterior wall, a posterior wall, medial, and the lateral wall. So the medial wall is formed by the upper four ribs, the serratus anterior muscle, okay, upper four ribs and the serratus anterior muscle, upper four ribs and the intercostal spaces there with the intercostal muscles as well as the serratus anterior will form. Then the anterior wall of it is formed by the pectoralis major, pectoralis minor muscle, okay, pectoralis major and pectoralis minor muscle. And the posterior wall here is formed by the teres major, latissimus dorsi, subscapularis, okay, scapula here. So that will be the posterior wall. The lateral wall here, it is very narrow. It is formed by the intertubercular sulcus and the structures within it. That is the long head of the tendon of the long head of biceps is present here. So that forms the lateral wall. So lateral wall is the most narrow part. So what are the contents there? Basically, the axillary artery is the main content. Okay, axillary vein is there. Then the cords of the brachial plexus are there. Okay, cords of brachial plexus. Then axillary pad of fat and axillary group of lymph nodes. So they form the main contents of the axilla. Okay, so you can see here. So that is what you need to write for boundaries and contents of the axilla. So next we go to superior radio-ulnar joint. Now, superior radio-ulnar joint is, so any joint, the type of joint, the articular surfaces, ligaments, movements, and clinical importance. So here the type is, it is a What type of joint is it? It is a pivot because it just moves like this, right? The head of the radius, okay, will move in the ulnar notch through this annular ligament that will be holding it just like a pivot. So it is a pivot type of synovial joint. So the articular surfaces, it is formed by the head of the radius and the radial notch of the ulna. Okay, so these two articulate to form the superior radioulnar joint. Now this joint is held in position by the annular ligament and the quadrate ligament there. So mainly it is the annular ligament, okay, which is extension from the capsular ligament. It will be holding. So within that, it will be moving. So basically what movements it brings about? It brings about the supination and pronation, which is brought about by the supinator as well as pronator teres and pronator quadratus muscle. They bring about the supination and pronation. Here at this superior, it is by the pronator teres. Okay. So you can see supination when the palm faces anteriorly. Pronation is when the palm faces posteriorly, like downwards, okay, in the anatomical position when we say. So here what is important in children, no, since the ossification is not completely ossified, it results when we try to hold the child by the forearm, okay, and try to lift the child, there are chances of dislocation, okay. So that is because, see here, it is not ossified. The head is separate from the shaft of the radius, okay. So that is why this joint is not very stable and it results in what we call it as pulled elbow. Okay, so those are the things which you need to write for superior radioulnar joint. The next question is flexor retinaculum. So what do we mean by flexor retinaculum? What are its attachments? The structures passing above and below. Okay, and the clinical importance. So when we see what is flexor retinaculum, it is the modification of the deep fascia. So why is it there? Because it provides stability for these, it holds all the tendons, no, the long flexor tendons in place when they pass through it, pass below it to get attached to the bones of the palm. So, and since it holds them in place, it prevents the bowstringing of these tendons, long tendons. So where it is attached? So it is attached like laterally, it is attached to the tubercle of the scaphoid and the tubercle of the trapezium, and medially to the pisiform and the hook of the hamate. Okay, so so beneath that, it forms an osteofibrous tunnel, which we call it as the carpal tunnel. Okay, so above that, you have to remember what are the structures passing from medial to lateral. So you remember NAP. Okay, NAP3. So what is this NAP3 is? N is ulnar nerve. Okay, ulnar nerve. This is ulnar nerve. Ulnar nerve. A is ulnar artery. And three P's are, one is palmar-cutaneous branch of ulnar nerve, okay, palmar-cutaneous branch of ulnar nerve. Another P is palmaris longus tendon, okay, palmaris longus tendon. And other P is palmar-cutaneous branch of median nerve, okay. So those are the three. So NAP3 you can mention. So below that, here, it will send a slip which is attached to the first, which is attached to the scaphoid here, okay? And it forms a separate compartment for the flexor carpi radialis tendon. So here beneath that, all the tendons of flexor digitorum superficialis and the tendons of flexor digitorum profundus, they pass through the median nerve, then the tendon of flexor pollicis longus. So for this, the covering will be the radial bursa, and for this, we will have the ulnar bursa. Okay. So this is the content. So what happens there is mainly applied aspect. You write about the compression of the median nerve, which results in carpal tunnel syndrome. Okay, so that is about the flexor retinaculum. Then extensor retinaculum. So same thing you write. So extensor retinaculum is again, okay, modification of the deep fascia, okay, which is seen on the dorsal side of the hand. So this holds all the extensor tendons in place and prevents the bowstringing. Okay, so where is it attached? Okay, so if you see its attachment is to the pisiform and the hamate on the medial side, and to the lateral side here, it will be attached to the styloid process as well as to the lateral border of this radius. Okay, it will be attached. So this extensor retinaculum, no, it is divided by from the retinaculum sensing the septa and divides the entire stretch into 6 compartments. So you should know what are the structures passing through each of the compartment. Okay, so if you see from this thing, so the first compartment will be here, the 2 muscles going to the thumb. Okay, that is the extensor pollicis brevis and abductor pollicis longus. Okay, extensor pollicis brevis and abductor pollicis longus. Second compartment will be extensor carpi radialis longus and brevis. Third compartment will be 1 muscle, that is extensor pollicis longus. Okay, radialis will be going to the here you can see. Okay, and then 4th compartment will be the extensor indicis and extensor digitorum along with 2 nerves. Okay, first, that is the 4th compartment. It is asked as an MCQ question and also like a spotter question. Okay, so 4th compartment structures are important. That is extensor indicis, extensor digitorum, and posterior interosseous nerve and anterior interosseous artery. So the 4 structures we see within the 4th compartment. 5th compartment is extensor digiti minimi, and 6th compartment is extensor carpi ulnaris. So in a section, we see it like this. Okay, first compartment, 2nd, 3rd, 4th, okay, as well as 5th and 6th. Okay, so basically here, in the extensor retinaculum, what happens is sometimes there will be this ganglion, no? So sometimes it can, because the posterior interosseous nerve passes beneath that and ends in a ganglion. So sometimes that can, usually it is not painful, but sometimes it can lead to pain during the movements, okay? And it can compress. So that is about extensor retinaculum. So you write it under these headings when it is asked as a 3 marks question. So with this, we finish today's class. Thank you for watching Auricle. If for more social media content, you can use the handles that is for the more content. No, you can follow the social media handles. That is YouTube, Instagram, Facebook, as well as Telegram. And you can download the app on Google Play and App Store. So see you next time. Thank you. Bye.